After I had this letter and had a chance to really reflect on what this meant and what the impact that meant to our patients, it became obvious that delirium wasn't something that was innocuous or not important, that we really had to understand this better. And that really changed me entirely from a career of basic science down this pathway of clinical research and specifically looking at delirium and the factors that may impact upon that. So as we did some more investigating of what delirium meant to our patients, we looked to see how frequent it was. And so when you just walk around the unit, go, well, that patient's delirious. Well, so is that one. And so is that one. And it became obvious that what we kind of discounted as not being very frequent was extraordinarily common. Then we looked at the next step. What happens to these patients after they leave the ICU? What often happens, they still remain confused. We don't really do a really good job of fixing it once it occurs. The best job is to try to prevent it before it happens at all. And that's really where we're focusing a lot of our attention. However, if they are confused, and they tend to stay confused for some time, and when they leave the ICU where there's less direct nursing care of one-to-one nursing care, they go to the ward. And just by virtue of being on the ward, one nurse may take care of 5 or 6 patients, and even more sometimes at night. So to help keep these patients safe, we take someone who sits at the bedside, a volunteer or a paid caretaker, if you will, or someone we call constant care. And they just sit at the bedside and try to keep Mr. Smith there or Mrs. Smith in bed and keep him from falling out and so forth. And again, we didn't know how common that was, so we just looked to see what we spent on a year for that. In 1 year, we spent $250,000 on a person just to sit at the bedside who's not a direct healthcare professional to prevent Mrs. Smith from falling out of the bed, which seemed astronomical to me. And we had no idea how this problem occurs, how frequently it was occurring, and really what we could do about it. And that, again, was a real aha moment for me to say, well, we have to do something different. As we've looked through this sort of systematically, we've examined patients over a year period and tried to determine what are the risk factors for delirium. And we identified 7 key things that can be identified before someone comes through an operation. We're now working with the whole team, which is really relatively unique for us here in the center and really in Canada, to develop a pathway where we can identify people at risk for delirium, involve them and their families at the time when they're first seen, all the way to the point where they're discharged from hospital. If they do get delirium sometime during that period of time, we try to develop new techniques to minimize the duration of it. And when you have delirium, it's sort of like taking a number of pills. The more pills you take, the more side effects one can get. The more delirium you have, the more side effects of long-term negative outcomes that can occur. So we're trying to find ways to minimize the duration of delirium and then also know what happens to them once they leave us in the hospital. So we're bringing patients back again 3, 6, 12 months after their heart surgery to see how they're actually doing, because we don't really know once they leave us how well they're doing or how well they recover.